that would decrease. So we really want to have, the best circulation possible. When you deal with HVAC systems, most schools have industry standards in regards to their HVAC. That should be sufficient enough. And the only thing we can recommend from Infectious Disease Society is that you properly maintain your HVAC and it's properly serviced. And it should be sufficient enough along with the ventilation of open windows.
Great. Dr. Burns, do you want to add to that?
No, I think Dr. Rosenbaum got it. Mostly the issue with regards, I think, with that aerosolization is the transmission of virus has to do in large part to the location of where it's either it enters the body, either through the nasal passageways, the respiratory tract, the eyes, the mouth, and the amount of the inoculum, the amount of viral particles that are actually exposed. And so if you can dilute that out with regards to air quality, and you're diluting out how much virus would be in the air, then that you're reducing the transmission risk in that way.
Right. One of the things that we, that's been put out is, windows opening and box fans in windows blowing out, not in. And not having fans blow on people, but instead blow out windows, and having doors open to classrooms so there's a cross ventilation that will naturally happen in addition to our HVAC units. So I appreciate that. Dr. Redlich, the NJSIAA is our sports governing body. This is a question from a parent. What are the doctors thinking about return to play of full contact sports right now? The NJSA is still moving forward with their plan for full contact sports come October. They put a blackout period starting next week going to September 14th. And then as of now, they're doing that. What are your thoughts on that? And I think you were involved in that part of it as well, if I'm not mistaken.
I was not involved with the decisions on what level of sport is what risk for what.
Yeah.
For what. However, the New Jersey Department of Health put out guidelines last month that talked about different levels of low, medium, higher risk of exposure of getting COVID, and they laid out when those activities were able to start. Listen, I mean, there are some sports and activities that are going to be, more at risk, like close contact. Activities like wrestling, like football. You're not going to be able to stay with the outside of 6 feet. Already that modifications are done for certain activities, like the band, which has been spacing themselves out more. I know I've seen that on the field as well. Other sports are less risk. You have tennis, you have golf, you have even some of the track sports. Everyone's running in the same direction as opposed to directly opposed to one another. Breathing on one another, spitting, and whatnot. So it is going to be a risk for those who choose to decide to engage in those higher risk sports. If again the NJSIAA continues to permit those to move forward, as we've already seen, we've seen some local school districts. I think there was a question that talked about that. They've decided to opt out of that. Like I think it was Princeton or
West Windsor.
West Windsor and Trenton decided to opt out of football and possibly wrestling. And just recently, regarding one of the questions on the indoor air, transmission and gathering, I think gymnastics and volleyball was just recently indicated that those are going to be tabled. Now, as far as what is an alternative plan for still allowing the athletes to participate in sports, right now you're seeing some of the benefits as they are having summer conditioning programs going on for several of the teams, where they can maintain a social distance, as the best as possible. For those of you on the call who are not aware, there are different phases of how an athlete can, get started or get or return to their sports. So you start off in groups of 10 where they're socially distanced, and that group of 10 is coupled with a one particular coach who's wearing a mask. And again, just like we've alluded to earlier, before they even are admitted to the practice, they have a temperature screen and they answer their questionnaires. And then they go on to do their practice. And currently now, the practices are all outdoor. So they can, participate in exercise, be with their team. As was also mentioned, there's a lot of psychological, mental benefit to being involved in sports and extracurricular activities. And right now, the safest way is to try to keep that distance. Whether or not it really moves forward and football and wrestling and other sports play, that remains to be seen. But it definitely is a higher risk, and there may just not be enough teams that that also choose to continue to take that risk. You're also seeing some of the collegiate teams have canceled some of their sports, or actually, there is a plan in place for some of the schools to try to do some of the fall sports in the springtime when things sort of ease up a bit more. So we may end up seeing that. That may end up being one of the better options to consider. I know there's arguments that talk about some of the the collegiate outbreaks have been from some of the teammates getting together and parties and whatnot. That also needs to be emphasized by coaches and leaders of these extracurricular groups to really listen. If you really want to engage in this activity and you want it to continue, and we want to have this go forward, you have to do your part, not just in the practice, but also outside of practice and outside of school.
Thank you for that. And just so everybody on the call knows, we are closely monitoring it every day. I know at the middle school level, 6 out of the 8 teams in the conference have canceled their middle school programs for the fall. We have not. Millstone has not, and actually there's 9, and Hopewell has not. But we're closely monitoring that as well. Like Dr. Redlick said, playing no teams will be hard to create a schedule. But we're working on that, and we're monitoring that, and we certainly want sports for our kids, but we also don't want to jeopardize their safety as a result of that, and we certainly can't schedule something if there are no teams to play. So we'll keep you posted on that. Dr. Rosenbaum, there have been many preschool daycare centers that have opened and have been open for a couple months at this point, and there has not been a large outbreak from my knowledge. Those, and I'll give you an example. I know of a Kiddie Academy. Their policy is positive 10, no masks for the kids, masks for the teachers only, and there has not been an outbreak at that age level. Any rationale or thought process on that?
That's a good question. So I'm not aware of that daycare that you discussed, but I can only, hypothesize possibly why they haven't had any outbreaks, and I hate to use the word outbreak, because when we deal with
outbreaks,
it's
bad. It's sort of a movie, yeah. I guess the better term is they haven't had positive kids, or they haven't had a large amount of positive or COVID cases at their facility of their students or their children. That being said, I think they probably did it in a safe and responsible fashion. I think they probably followed guidelines to the T. I think they probably had strict policies and procedures in place. I think they really had a joint collaboration between faculty as well as parents. We can do everything we want to do as faculty and staff at the facility, but there's a significant amount of responsibility that the parents must own as well too. Days of loading your child up with Motrin before they go to school, really, just to get them out should not be done anymore. The days of kids having sniffles and it's okay, it's a common cold. Those days are long gone. Nowadays, if kids have sniffles or they have runny nose, it could be potentially COVID, and we have to take it seriously. So that being said, I think maybe the daycares had, I don't know what the child care classroom sizes are, what their spacing of classes or sharing of equipment.
but they probably, masked properly, like you said. They probably did temperature checks. They had good collaboration with parents. Everyone was educated on evaluating kids. And they followed policies and procedures to the T based upon evidence-based medicine from the CDC, the WHO, and the Department of Health. That would be my guess at that point.
Is there, and this is sort of a follow-up to that question, and then I have a question for Dr. Burns, and obviously anybody can answer this question. In terms of ages, like are you seeing, there's a lot of, I don't know, many people don't know what to believe anymore in terms of ages, who gets it, who doesn't get it, who's getting sick, who doesn't get sick. Is there an age range or something that shows a less transmission in an age, or talk to me about that.
It's funny you say that. I was just reading an article that hot off the press from the Journal of Pediatrics that did the largest study regarding children ages upwards. Actually, they included some adolescent teenagers, and they found that kids, more importantly, younger pediatric patients had a higher viral load in their nasopharynx when they were mildly infected or asymptomatic, as compared to adults who were critically ill. So what that showed is that there's a higher degree of transmission rate with children, even if they are asymptomatic or if they're mildly ill or mildly presenting symptoms. So they really posed that into, the academic facilities and the institutions in regards to reopening policies to think, just because we're screening questions and we're temperature checking, that might not be enough. We have to really, take into account that kids can really transmit the virus at a higher rate, especially if they go home to parents that are elderly or immunocompromised, or they can transmit it to other kids in the facility. In the beginning of the pandemic, we saw in the hospital, I should say, patients were of the elderly range. They had a lot of the comorbidities. They were the immunocompromised. And unfortunately, a lot of those patients succumbed to the illness. And as we progressed, we started to see more recently, the 22 to 39-year-old bracket start to be really the ones that are getting infected, albeit mildly infected, not critically ill like we saw in the beginning, but they're the ones who are now posing the biggest risk. Whether that's because the millennials are not following the social distancing rules, they're having these parties, as you alluded to, they're not masking properly. There's a bunch of reasons why people are hypothesizing, but the age bracket of the millennials is really where we're starting to see people be infected.
Dr. Burns, this has been a hot topic, and this is a parent question. New York City is trying to test all teachers and students prior to returning to school. Mm-hmm. What is your thought process on that? And I know we've talked about it. This is a reopening committee in terms of sort of the lag time between a test and results. So what is your thought process on that? Right.
And so what we're talking about is not the same as our screening protocols, which we've put in place, which are the temperature screens and symptom checkers. But testing actually for viral particles in a body fluid, either through a nasal swab, what's called a PCR test, or a saliva test, or an antigen test. The CDC nor the New Jersey Department of Health neither is recommending at this time routine testing for schools. There's no data to base that it would be of any benefit. The issue with it is feasibility. There's a host of issues that are involved with regards to a test. One part is cost, certainly. The other part is the time that you get to those results back, and are they really meaningful at that point? And then sensitivity, of course. You want a test that obviously is able to detect reliably. You can rely on that result, positive versus negative. Testing with increasing amounts of testing throughout the country, really for the past 6 weeks, has been a very real struggle. The number of tests that are being done, both in terms of people who are ill or were exposed to someone who was ill or were exposed to someone who was positive from a test, or was returning to work and needed a test to go back, or is going to a college dorm and needs to be tested for that. All that volume has overwhelmed our testing capacity. And what I've personally experienced in the office has been literally on a dime, my lab test results that I would normally swab and get back from Quest or LabCorp within 3 to 5 days via a nasal swab prior to 4th of July. After 4th of July, when the rest of the country started to really ramp up testing for multiple reasons, as I mentioned, my tests started coming back in 13, 14, in one case, 21 days. Those tests are sort of worthless. Not sort of, they are. At that point, it's really the person, if they were ill, has well recovered for the most part. And if you're trying to use that from a contact tracing aspect of saying, can this person be doing some activity? Can they move into that dorm? Can they return to work? Can they return to school? Those are greatly hampered by that time delay. When there's that time delay as well, it calls into question whether those tests are as sensitive as reliably giving your data back. If you're not processing that test in a timely manner, and we saw that with the Abbott ID Now, which was touted in April as going to be a great thing, that it was going to turn around test results fast, which is true, provided that it's done very promptly. And if there's a delay, the sensitivity of that plummets significantly, almost to the level of flipping a coin 50%. So that feasibility of being able to do it in a proper way, getting results back quick. Remember, it's if you test today, but you don't get the results back for 14 days, there's a lot of contacts and a lot of risk that a person could have had transmission-wise in that 14 days that makes that test result, not relevant. It's why facilities that are doing testing, outpatient procedures, colonoscopies, minor surgeries, or surgeries, they're testing but requiring the patient to quarantine for those usually 2 to 3 days before they get the test result back, because they don't want them getting other exposures in the time that they took the test to the time that they're going to do that procedure. At this stage of the game in the state of New Jersey, the testing is not that reliable to be able to do that on a grand scale, and that, I think, is a large part why the CDC and the NJDOH don't recommend it.
Thank you. Amy, question for you in terms of, this is a big question for parents. And just to give everybody some context, we have about 25% of our population going virtual only, and we anticipate approximately about 37% of our students in school in person each day. So if you remember, there's two groups, about 75%, divide that by 2, it's about 37%. So Amy, our plan for phase 2 is to have students eat lunch in school. And one of the reasons I'm asking you is, A, how does hospital staff eat lunch or eat food? Do they eat in a cafeteria or do they eat somewhere else? And then what do you think are some good advice for schools that are looking to have kids eat in school?
So I work night shift, so nothing's really open, but I know the day shift folks get to eat in the cafeteria. They have spaced out some of the larger group tables so people can just sit, socially distanced in the cafeteria area. In our nurses' lounge, we've separated our group tables and made them into smaller seating areas. When we're seated at the nurses' station, we wear our masks the entire time, but if we need to have a drink of water or a snack or something, we're socially distanced at our computer stations to begin with. So I think, we've talked about on the reopening committee about how we're going to have the kids eating and drinking. Obviously, that's a major part of their day. I think it can be done safely. Obviously, we want to take advantage of any great weather we have outside and get the kids outside as much as possible. Even if they have to put jackets on when it starts to get a little cooler. I think it'll give the kids a great opportunity to get some fresh air, kind of fill their bellies, and also maybe even socially distance, some more normal social engagement with each other. Again, if we have them seated in a cafeteria or in their classrooms, limiting the amount of time that they are without masks is obviously what we're trying to go for. And it's just going to be encouraging everybody to be really cognizant of those rules. Of course, the younger children in elementary school will be the most difficult to follow. But I feel like the older elementary and your middle and high school students should be able to understand the reason that they need to be socially distanced or socially distanced outside and eating. So I think it's possible. I think it's going to be, again, a risk, but we have to just be cautious and mindful. And I think that it is attainable. But everybody, just has to slowly and calculated risks and as we proceed on to the eating at school phase.
Great. Dr. Redlich, I'll ask you this question. One of the things that the quarantine, if students are forced to quarantine and they receive a negative COVID test, they're still required to quarantine for 14 days, even though they got a negative test. So I'll give you the example. Susie Jones' mother has COVID. Susie went for a test. She came negative, but Susie still has to quarantine for 14 days. Why, with a negative test, would someone still need to quarantine?
Well, so those are coming from the CDC guidelines for exposure to either someone who's known to be positive, or known to have clinical symptoms and be positive for COVID. And the reason or rationale, in my understanding, is that there's the incubation period that could be from a couple of days, for up to that many days out. Maybe Dr. Rosenbaum can speak to that specific time frame. But and my understanding is, so that that's different than where if you are determined that you have a positive test and no symptoms, then there is sort of a minimum number of days. Roughly, it's about 10 days where the minimum for which you could return back to, provided you have no fever, you're not on fever-reducing medication, and all of your symptoms have cleared up. It's sort of like you can get back in 10 days. That's the sort of the clinical return back. Now, if you are someone who is immunocompromised, cancer and chemotherapy, or you have a condition for which you take a medication that compromises you or reduces your immune system, the guideline sort of listed is that number's up to about 20 days. But I do think we as the school district and as a population and as medical professionals, we also look towards the like I said, the Department of Health to kind of guideline what we should do in terms of the quarantining periods of time, and in terms of what constitutes, let's say, who needs to be quarantined, and that's from looking at the contact tracing process. But maybe Dr. Rosenbaum can kind of elaborate or correct my thoughts.
So, there's a couple things that you have to look at it a couple different ways. It is somewhat complicated, but everyone's alluded to. The thing with the PCR testing is that it's a snapshot in time of when you take the test. So, Dr. Redlich gets tested today. It doesn't mean, just because he's negative today, doesn't mean that he isn't incubating the disease at the time of the test. The incubation period can be anywhere up to 14 days, with a median of around 2 to 5 days of incubation. So, they want people, part of the whole, return to work, or the coming back from a state that's been identified as a hotspot, is that just because you have a test, we still want you to be home for 14 days because you still could be incubating at the time of the test, even though you're negative, and then you could return to a work or return to a school, and then you become symptomatic, and then you become positive, and then there's a higher degree of you transmitting the disease. When you talk about the return to work or return to school, the CDC has moved now to what we call a discontinuation of isolation, from a discontinuation of isolation or return to a work environment using a symptom-based strategy rather than doing a repeat test, just because we know now that after about 90 days or so, or even more, like even after 10 days, I should say, the amount of what we call competent cells is decreased significantly, so the risk of you transmitting is lower. So that's why that 10 days that Dr. Redlich talked about is used now for people that come back after they've had a positive test. You have to be afebrile for 24 hours. It has to be 10 days since your positive test, and you have to have improvement of the symptoms that initially made you to have the test. So it's very complicated. There's a lot that goes involved, and that's why you really should consult, a healthcare practitioner in regards to the testing, as well as the return to work or school for that matter, and follow the guidelines.
Thank you. I have two more questions, knowing that we're right up against the hour. Dr. Burns, how much do masks matter?
Masks matter tremendously. There was a very good study that was in the Morbidity Mortality World Report, which the CDC references, which involved two salon. Most people probably have heard of this one by now, but the two salon workers in Missouri. The one salon owner, the worker, started to become ill, but continued to work, and while wearing a mask in her salon. On day 5, she was tested and was told to no longer work, but she did not do that, and she continued to see and perform in the job in her salon. On day 8, she received her positive COVID test, at which point she shut down her salon and for cleaning and so forth. One of her coworkers, salon worker B, had been around salon worker A, not wearing masks on break times, and she started to develop symptoms the latter part of that week, and was sick when salon worker A received a positive diagnosis. The contact tracers went into that salon once it was shut down, once they found out what had happened. Salon worker B had contracted her COVID from her coworker when not masked. They had, between the two of them, over the course of those 8 days, had seen a total of 139 clients in close proximity, cutting their hair. All the clients were wearing masks. They were wearing masks while they were cutting their hair. None of the clients became COVID positive. The cloth, the coverings that they wore, salon worker A wore a double cloth mask, much like we see a lot of people wear handmade ones. The salon worker B wore a combination of a cloth face covering as well as a surgical mask. But that really demonstrated the power of a mask, that you can, even in the absence of social distancing for longer than 10 minutes in that environment, with COVID positive people, can prevent the spread. So I think masks are essential to the safe operation of the school, which is why our plan included it, and then eventually the governor insisted upon it.
Mark, there's just
last question.
Mark, there's just a couple follow-up questions to that people have had. They're related to the masks. One is that the types of masks. Today, I know that we issued a directive to our staff and to the students that they were not allowed to wear the masks that had the vent in the front. They're not allowed to wear bandanas, and they're not allowed to wear those other
Gaiters.
Gaiters, thank you. I don't know why they're called that, so I keep missing that name. But there were a couple questions on here on the type of masks that are the best masks. And also there was a question that if a student has lung issues and isn't able to wear the mask, what accommodation are we making? And I know the district answer, but I think that the doctors, that would be a good question for them to weigh in. The rest of the questions are things that we will answer Monday night. The principals will be able to answer all these other questions on Monday night.
All right, so 2 questions, that one, and then I have one more for Dr. Rosenbaum.
Right.
So does someone want to take that one about masks? Which masks are best?
So the masks that have the vent in the front allow for air inflow. That is filtered, but on the expiration, on breathing out, that is unfiltered air, and therefore that defeats the purpose of the mask. The whole idea of a mask is to contain the expired air close to the face of the person, and not to have it being wafted across a room or area. So the vented ones do not do that at all, and so they are not really a safe face covering. The gaiters, there were some studies that came out most recently about it, looking at gaiters, and it really was based upon what the material was. A thinner material may not adequately reduce that airflow out with expiration. It may catch larger droplets, but that's not the intent as much entirely. We need to not only disrupt the large particles of an expired air, but also the smaller ones and contain them. And those gaiters or bandanas, the single ply cloth, do not do that. I forget what the second part was.
What type of masks work best?
Okay, well, yeah. So that was that part in terms of the double ply cloth face covering, the one that has 2 layers, or a surgical mask is ideal. The N95 mask is really only needed for high risk procedures. Really, I don't wear an N95 mask in my office unless I am at a high risk of doing a procedure that is aerosolizing fluids, and that's when I would switch from my own surgical mask to an N95. As for, I remember the second part of the question was the asthma.
Yeah, right.
The lung issues. The only real concern with the wearing of masks is for people with significant lung concerns, such as that would regard severe asthma, much like if they were oxygen requiring or oxygen dependent. To be quite honest, if someone has that severe of a respiratory illness, if they were my child, I would be having them attend virtually. And that would not be because of the need for wearing a mask, but that would be because of their underlying medical condition. I think that they would be at a higher risk should they contract it.
Thank you. Dr. Rosenbaum, last question of the night, and then I want to thank our panelists in a second. This sort of is a summation question, and this is an unfair question because there's no answer to it. So where is this virus going? Like what do what do we have to look forward to moving forward?
I've seen so much stuff on social media, regarding, when's 2020 over, or what can I take to forget about 2020, or all the memes are getting passed around. Dr. Fauci said it best at the beginning of the pandemic when he was asked on the podium, when is this virus going to be over? And the answer he said was, when it tells you it will be over. And I think that's really, the safest way to answer this. We don't know when it's going to be over, but I can tell you that it will slow down and we'll have a better chance of being over if and when we get a vaccine. Number one, I think vaccine is paramount to helping, control this disease. As Dr. Burns and Dr. Redlick and Amy have alluded to, we need to follow the rules. We have to wear our masks. We have to wash our hands. We have to stay home if we're ill. We have to take care of each other. These are things that are extremely important in order to not only contain the disease, but to mitigate the disease. Ultimately, this will probably become a chronic disease or a repetitive disease, such as influenza. Every year we're going to have to deal with it, and hopefully every year we'll be better prepared to deal with it. But until then, we can only do what we know about the virus, and that's changing by minute. So please wash your hands, wear your masks, stay home if you're sick, and help each other out, and try not to socially isolate. We want to socially distance, and I think that's important to remember. We need to be around each other. We need to socially interact. So whether that means Zoom calls like these, or doing socially distanced drive-bys to our loved ones who are elderly, it's important. We don't want to socially isolate. We want to socially distance. So that being said, I thank you for your time.
I appreciate that. And my last comment before I thank you guys is I think that all of you in many different ways said this, is that we're in this all together. And as a community, it's so important that we look at this as not a school issue, not a parent issue. It's a community issue. And if we can all band together and work together and, make sure that we're communicating and having real honest conversations about things. I think those are things that will help our district move forward, certainly at a rate that we hope it does. The other thing I would say to everyone is that, and our principals are on board with this as well, like there are ideas out there that we have not thought of. We have never been through a pandemic before. So if you have ideas that, you see something we're doing, it's not efficient, it's not the best way possible. We've obviously spent a long time looking at this and trying to plan, but there are people in our community who have probably better ideas. Don't hesitate to reach out to a principal, reach out to me. We had at the 5th grade orientation, we had a parent talk about share an idea that they're going to put into place because it was a better idea than we had. Like those are the things that we need to do together because there are ideas out there that are better. And with that being said, Nurse Rodriguez, Dr. Redlick, Dr. Rosenbaum, Dr. Burns, I can't think of a better group of people to sort of have this conversation and lead us in this conversation. And you never know, there might be a need to do another one of these at some point, and hopefully we can solicit you again for this. And I can't thank you enough for spending this time, and we really appreciate it and value your thoughts tonight. So thank you.
You're welcome.
You're welcome.
Thank you very much.
All right. Take care, everybody. Thank you for joining. We had about 1:30 at one point, so great turnout, and let's keep moving forward. Take care, everybody.
Good night.
Bye.
Good night.